Good evening, everyone. My name is Alpesh Patel. It's a pleasure to invite everybody and to welcome everybody to the webinar tonight. This webinar is called Spinal Biologics Demystified, Separating Fact from Fiction. It is sponsored by Kuros Biosciences, and we want to send a thank you to them and their team for their support in tonight's conversation. I'll introduce myself again. My name is Alpesh Patel. I'm an orthopedic spine surgeon at Northwestern. Sorry for that. I'm joined by two of my faculty members here with me, good friends of mine, Dr. Drew Sama, who's the co-chief of spine surgery at HSS in New York, and Dr. Fahim Sandhu, who's the director of spine surgery at MedStar Georgetown University Hospital in Washington, D.C. As a quick disclosure, myself, Drew, and Fahim are members of the Kuros Biosciences Surgeon Advisory Board. We're all early users of some of the products we'll talk about today, but we're going to do our absolute best to maintain, full transparency and talk about a lot of things that may or may not be, Kuros related. So with that in mind, I want to welcome Drew and Fahim. Thanks for your time tonight, guys. And we will get started. I'll walk everybody through the agenda real quick, and then we'll get going. We will say that this is going to be maybe a little more informal than most webinars. That's intentional. We want to have it more of a conversation amongst the three of us plus our audience so that we get a chance to maybe get some ideas across that are a little bit more interesting and a little more engaging than a typical webinar. This is our outline. This is what we hope to accomplish over the next hour with you. We're going to separate fact from fiction. We're going to talk about, first and foremost, hype versus evidence. We're going to then have a great technology update. We're going to talk a lot about safety and outcomes, points 3 and 4. Our faculty members tonight have got a couple of great cases to go over, and we'll dig into some details on those cases. And then the last thing we'll wrap up on, which honestly sometimes is top of mind for many of us, are the costs and the cost implications of the work we're doing. With that, I'll pass the microphone over to Drew and have him walk us through the first section talking about hype versus evidence. Thanks, Drew.
Thanks, Alpesh, and thanks for the opportunity to be here. I'd like to take the opportunity to welcome everyone for joining us. And if any questions, as Alpesh said, please put them in the chat. So my charge today is to speak about the hype versus the evidence in osteobiology and looking at the 4 O's of osteobiology. This is going to take us all back to medical school for a little bit, and hopefully it's not too basic or not too dense. But when we think about the first O, it's osteoconduction. As you remember, osteoconduction is the ability of a biomaterial to support bone growth onto its surface. So the material actually acts as a scaffolding. This is basically passive guidance for bone growth. So this gets placed in the area where you want to put your bone and where you want new bone to grow, and then the structure of the biomaterial acts as a scaffold to allow bone to grow onto it and guiding that new bone to form. Typical types of osteoconductive materials are patient's own bone or autograft. We can use allograft or cadaveric bone or a donor bone. And then there are some synthetics such as calcium phosphates, hydroxyapatite, and tricalcium phosphate. Bioglass also falls under the topic of osteoconduction, and polymethyl methacrylate can also be osteoconductive. The second O is osteoinduction. Some of these words sound alike, but obviously they're very, very different. Osteoinduction is actually the process by which the material stimulates the body to actually form the bone at the implantation site. So this is a stimulation of the biologic response that then causes bone to grow. There's signaling molecules that induce the surrounding cells in the bed where you want the fusion or the bone to grow to differentiate into osteoblasts to actually produce viable and living bone. Some examples of these are signal-driven recruitment cells for bone-forming cells. So the things that cause this that we use, or the things that kind of incite this, are things like bone morphogenetic protein, or BMP, And also demineralized bone matrices have been shown to be osteoinductive. The third O is osteogenesis. Osteogenesis is the actual process of bone formation. So far, we've talked about the scaffolding, then the signaling, and now we're talking about the actual bone formation. This is direct formation of new bone, and it can be stimulated by the use of live cells. Obviously, we'll talk a little bit later about safety of using live cells. There are some inherent risks to that. The cells that are placed there or the response that occurs there is actually the cells building bone. Autograft from the patient's own body contains live mesenchymal precursor cells, and that is a type of osteogenic material. The growth factors, some of which we've already talked about, like BMP or bone morphogenic protein, that can also be osteogenic. TGF beta is also osteogenic, as is platelet-derived growth factor, which also promotes cell growth and migration to the bed where you want the bone to lay down. VEGF also stimulates the formation of new bone. And this works in conjunct with the stem cells, either from the patient or there are some allogeneic types of stem cells too, which we'll talk about a little bit later. These are typically mesenchymal types of stem cells, and they differentiate into different cell types, such as osteoblasts. There are bone marrow-derived stem cells, which promote a specific type of MSC from the bone marrow to become mature bone-forming cells. There are embryonic stem cells, which come from embryos and differentiate into various cell types. The typical chemical pathway induces pluripotential stem cells to mature and differentiate into adult bone-forming cells that become the basis of the bone formation. We'd like to take the opportunity to introduce the fourth O of osteobiology, and that is osteoimmunology. So this is where the immune system of the host of the patient that you're implanting the bone into helps to regulate bone regeneration and bone formation. The immune environment locally is the missing variable in some of the predictability of some of these bone biology pathways. We've come to learn that nanoarchitecture of the material can influence how some of these immunological cells, such as monocytes, are polarized. And when they polarize, they can basically differentiate into either pro-inflammatory or pro-healing types of macrophages. And then based on the lineage of those cells, they can come on to be fibrous tissue through the inflammatory cascade, or more appropriately and more desirable, they can become bone-forming cells through the pro-healing macrophage lineage. The macrophages signal these stem cells to differentiate into osteoblasts, and then the osteoblasts can form bone. So one of the things that we've come to learn about is through these micro and nano architectures, synthetic materials such as MagnetOs can directly lead to the polarization of these monocytes into M2 macrophages, which then go down the bone formation pathway and cascade. We've come to learn over the years that the skeletal system and the immune systems are inextricably linked. Inhibiting a patient's immune system can increase the risk of non-union in the spine, and we've seen this in the literature play out. We know that glucocorticoids and non-steroidal anti-inflammatories have been shown to have a deleterious effect in bone formation and in fracture healing, as well as in fusion formation in spine surgical patients. When we think about some of the typical types of bone graft substitutes that we use, or some of the bone grafts actually that we use, such as autograft, and then some of the substitutes like allograft, DBMs, first and second generation synthetics, advanced synthetics, and then cell-based allografts, peptides, and growth factors, we can see on this chart with the four O's which materials portend which properties. So most of all of these are going to be osteoconductive or viable scaffoldings. Some of them, as you see in the table, are actually osteoinductive. Two of them are sanctioned by the FDA to be considered osteogenic. And then the advanced synthetics are osteoimmunologic in addition to being osteoinductive and osteoconductive. When we think about how we support these claims and how we think about which are the best substrates to use for our patients, we know that there are level one data published based on bone graft categories. When we think about biological types, we talked a little bit about growth factors, peptides, advanced synthetics, et cetera. Common examples of these are named there. And then if you look on the far right column, sorry, you see who has level one published data. So for BMPs and peptides, as well as advanced synthetics, there are level one papers. There are some specific DBMs, such as Grafton, that has some level one data. And then there are some specific synthetics, such as Vitas and Atrax, that have some level one data. Most of the other studies are level three or level four data. So how much evidence is enough? Alpesh?
Yeah, exactly. Drew, thanks for that that good summary. I think, I think these concepts around um, uh, basic characteristics, right, of biologic products is really important to have. I think it's an important vernacular to make sure we share. Drew and you and I both have a background in orthopedics, right? So it's sort of fundamental to, I think, what we learned maybe even in boot camp. But this fourth O, this idea that the immune system has a critical role in bone biology is still, I would argue, relatively new. I certainly wasn't fully aware of it until maybe the last 7, 8 years. And I'm becoming more aware of it as time goes by. And it's this concept that, we've always thought of the immune system as a potential hindrance, right? You mentioned that in folks with immune deficiencies, whether that be pharmacologically induced or otherwise, tend to heal slower. They tend to have non-unions. This seems to be a thought process that maybe the immune system's an ally, right? And we have ways to harness it. Fahim, I'm curious, with your background, your experience as a neurosurgeon, how prevalent are these kinds of conversations in neurosurgery training when it comes to bone biology, if you will?
Yeah, great question. And I think, it's changing in neurosurgery as we do much more work in the fusion arena. And we certainly talk about it with our residents more. I think, obviously, compared to orthopedic training, it's not as rigorous probably on the basic science end, but I think now as a lot of this new biology, osteoimmunology has been kind of unraveled. We're certainly having those discussions. We have journal clubs centered around bone healing, bone biology, but I think it's a very important topic and very relevant to anybody, regardless of specialty, who does fusion work.
Yeah. Drew, what are your thoughts? What's our best mode of bringing this kind of information, especially around the immunology side of things, to more people so that they can understand it just a bit better?
I mean, I think it's an exciting field just in the sense that, as we learn more about modulation of the immune system, you can actually see how it kind of plays into different parts of bone growth and bone formation. There was one of the questions in the chat here by Jeff Kleiner, who talks about overlooked process that occurs in the inner body space. It's end plate to end plate contact. Maybe there's a fifth O. Can you comment on the challenge that inner body implants face when grafting occurs before distraction and post packing is difficult? I think, when we think about this and we start talking about these different types of implants, back to your question, Alpesh, we're challenged with new ways to think about bone biology because of the local environments that we're working in. So in years past, where we used allograft as the interbody spacers, and now we're using titanium implants, in some cases PEEK or other types of materials that are expandable, we're kind of facing this, well, some of these materials are more or less osteoconductive, osteoinductive, but really the underlying immune environment there is something that we may be able to kind of modulate better based on the nano architecture, what we're putting into those challenging environments. So using something as a post packing for the like in Jeff's question here, if you have a cage that's difficult to post pack, there are some flowable types of synthetics and advanced synthetics that do have the ability to kind of trigger local immune responses and local osteogenic types of environments.
Yeah.
The way we teach it, I think we just teach it through our residencies. Hopefully, the medical school stuff gets a little bit more fleshed out, if you pardon the pun, that it basically they're teaching it with more detail and more specifics towards the osteology part of this, not just the immunology part of it. But I think in the orthopedic world, we teach it to our residents. And as Fahim suggested, as more and more people are doing these different types of operations, we need to teach this at a very fundamental level across all areas.
Yeah, and
Let me pivot
Drew,
the discussion just a quick bit to talk about the evidence component here, right? I think it ties into how we educate ourselves and educate others around here. Drew, you did a really good job sort of summarizing, what we have evidence in and what we don't. And I think a lot of times, for a lot of my experience as a surgeon, the biological components of the work we do sort of played second fiddle to the implants, right? We were such an industry focused on implants, whether that be screws or interbodies or what have you, that the biologics were oftentimes like an afterthought, right? And we're now at the point where I think we all want to be a little more critical and thoughtful about our biologics. So I guess the question to both of you, and maybe Fahim, I'll let you answer first, is, how do you look at evidence, if you will, when you're trying to make a decision around a biologic product? Like how much evidence do you need? What sways you? What doesn't? What's the ways that you break down evidence when it comes to biological products?
well, I think like all of us, I would hope, level one evidence is really, the best that we can hope for. And I look for that in, biologic agents that we use for fusion. For many years, infuse worked well. I mean, it was very expensive. It wasn't for every case initially, and but it had great evidence. There was level one studies, and I felt that was reliable. And then when I started using it, those results were reproducible as you would expect. And I think similarly, for reasons in probably 2017 timeframe, as there became more evidence of some issues related to BMP use. I was definitely not alone in my desire to kind of move away from it for, complication reasons, cost reasons, and at the same time, MagnetOs became available and also offered level one evidence for using it in spine surgery. And just in comparison, I I have used other products, the cell-based matrices, a lot of other synthetics, but I think my results have been, you know, less than optimal with some of the other materials, and I think that also reflects the level of evidence in some of the other materials that are out there. So I don't know if Drew, you have a similar experience, but um,
Yeah, Drew, let's build on that just really quickly before we move on to the next section, which is you mentioned again that there's so much variability in the amount of evidence, not just the amount, but to Fahim's point, the level, the
Sure.
granularity and the maybe the rigor of the different products. It seems like there are some products out there that have put out just enough evidence to get to market, right? They figure out what the regulatory hurdle is. They just clear that hurdle to get to market, and then they let it roll. And then there are others where we're looking, to Fahim's point, to really strong level one, level two evidence, right? What are your thoughts on that? Are we looking at the right degrees of evidence? Should we as a group of surgeons be more critical about biologic products than we have been in the past?
So, I mean, I think, when you're basing how you choose your products on data, then you want the strongest possible data that you can have. And to your point, the predicate data for the FDA submissions is basically to get across the threshold. But then what we start to see, which is really exciting, I think, is as these things become utilized, you're going to get user data that's really not influenced by very selective patient groups for the FDA trials. It's not going to be influenced by industry that's sponsoring these studies rather based on their products. So that's the exciting part of the data for me, is like when you start to see it in everybody's hands and see how the outcomes are better or worse with different types of products. And we've all experienced that. And we've actually probably published on that too, where, hey, I thought this was going to be great. We used it, and after 2 years, we realized that it's not really doing what we wanted to do, or vice versa. Hey, we were skeptical about this. And, after 2 years, we see that it has 90% or higher success rate for some of these things. So that's the type of data that I look to personally when I'm trying to pick my products.
So I would say, because we got to keep moving, I'm already getting messages that we're behind schedule. So we'll keep moving. I think the takeaway for me in the discussion so far is that I think we should be expecting high levels of evidence from the products that we use. I don't think we think of biologics as throwaways or as tack-ons, that they really end up being a really critical component of the work we're doing if we care about fusion success. So our second part is a quick tech update. We're going to dive deep with Dr. Casey Hatfield, who's a PhD. She's the Director of Medical Affairs at Curos Biosciences. And she's going to give us a deep insight into some of the mechanics and some of the biologic actors, if you will, that go into some of these responses we're talking about when it comes to nanosurface technologies. She's promised to keep it simple because I'm just an orthopedic surgeon. It's got to be really simple for me. But luckily we have Dr. Sandhu with us, who's a neurosurgeon and can maybe help us understand it better once she's done. So Dr.
Thank you so
Hatfield,
much, Dr. Patel.
yeah.
Thank you so much. My name is Casey Hatfield, and I'm the Director of Medical Affairs at Curos Biosciences. As Dr. Patel mentioned, I'm going to give a brief update on our bone graft MagnetOs and discuss how some of those O's that Dr. Sama discussed apply to the bone graft MagnetOs. Over the past few decades, there's been a convergence in research between the graft and other implant space. In the 1990s and 2000s, research came out suggesting a role in porosity for both bony ingrowth as well as retention of mesenchymal stem cells. More recently, literature has been published showing a role for the submicron surface of materials for polarizing immune cells to promote predictable healing. This slide summarizes a few calcium phosphate-based grafts, and you can see they each have vastly different surface topography. Kronos, for example, has these large flat macular granules and minimal porosity, while MagnetOs has a submicron topography composed of submicron needle-shaped structures. This is what a MagnetOs granule looks like macroscopically, and then zooming in, you'll see these needles come into focus. The needles of MagnetOs provide traction for pro-healing M2 macrophages. These macrophages then recruit in mesenchymal stem cells and provide the necessary instruction for them to differentiate into osteoblasts. On the opposite side, other materials promote a pro-inflammatory pathway that's predominated by these M1 macrophages, leading to scar tissue formation and non-unions. At Curos, in addition to having a well-defined mechanism of action, we have preclinical evidence showing how MagnetOs works in vivo. This was a canine paraspinalis muscle pouch study where MagnetOs and 6 conventional grafts were implanted via blunt dissection. After 12 weeks, they were removed, sectioned, and stained with histology. You'll see bright pink throughout the core of the MagnetOs graft, denoting bone formation, while most of these other grafts were fibrous tissue, denoted by the bluish-purple color, or a residual graft, the brownish-black. This is the first study that revealed that MagnetOs can grow bone in the absence of pre-existing bone, as well as added cells or growth factors. This is growing bone by itself in a muscle pouch in dogs. Next, we turn to a clinically relevant instrumented posterolateral fusion study in an ovine model. In this study, we noticed creeping edge repair from autograft at 6 weeks, suggesting that it's serving as an osteoconductive scaffold. In comparison, we saw a creeping edge repair occurring from MagnetOs, but if you look in this turquoise circle, you'll also notice that each of the granules is serving as a nucleation site for new bone to form. At 12 weeks, we saw complete bridging bone in both groups, and 26 weeks, healthy remodeling characteristic of trabecular bone. We have over 20 human clinical studies that have been initiated as well. These can be found in our global research summary. Of note, based on the discussion prior with Dr. Sama, you'll notice that we have a number of human clinical trials that will reveal level 1 evidence, one of which is published in Spine. This study was an investigator-initiated, prospective, multi-center, intra-patient controlled study looking at posterolateral fusion where MagnetOs granules were placed standalone with no other graft material on one side of the spine, and autograft was placed standalone on the opposite. The autograft had to be at least 50% iliac crest derived and was volume matched to MagnetOs at each level. 91 patients received fine-cut CTs at 1 year post-op that were evaluated in 3 planes by 2 independent blinded spine surgeons. What they uncovered is a 79% fusion rate with MagnetOs, while autograft fused 47% of the treated levels. This study was powered for non-inferiority, but the authors even indicated superiority in the discussion of this manuscript. To illustrate one example from this case, this is a 70-year-old female who had a 4-level posterolateral fusion with MagnetOs placed on the left side of the spine and autograft on the right. MagnetOs fused all 4 of the levels in this patient, while autograft fused 2 of the 4. And you'll notice even at those 2 levels, there's more robust bone formation in response to MagnetOs. So to conclude this section, a few things that distinguish MagnetOs are a clear mechanism of action rooted in immunology, high-quality level 1 evidence, and the ability of MagnetOs to form bone in a muscle pouch in a canine model without the need for any added cells or growth factors or cadaver-derived tissue. And so with that, I'm going to segue over to a safety discussion with Dr. Sama.
Hey, Casey, before we have Drew pop up, can we keep you on camera for a quick second?
Absolutely.
God, you have such a wealth of knowledge on this, and I want to break our agenda just a bit and ask just a couple questions. So a lot of the information you've shown, obviously I've seen it before, but it may be new to a lot of people in the audience. What I took away the first time I saw the data, was the investment of time and effort that you guys have made into actually having, bench to human data, right? That full spectrum of data that, again, back to our conversation earlier, kind of goes beyond the bare minimums that we sometimes see in the space. We see the sort of de novo bone formation, right, in the muscle pouch. That's pretty exciting. To be clear, that's not osteoinductive, right? We're not saying that it is, but it's pretty exciting to see that. One of the questions that's often brought up is that, when we see that type of bone formation, right, kind of coming from the outside in, we as surgeons sometimes get worried that, we're just getting a thin film of bone forming, right? What does the basic science tell you about actual bone formation? Do we get bone growing through the graft material? Do we get vascularity? What do you see at a cell level?
Yes, that's a great question. We see bone growing through the core of the graft, and when we look at higher magnification of that histology, we see healthy lamellar bone. So osteocytes, osteoclasts, osteoblasts all interacting and forming new bone. We also see in vitro in cell culture assays the ability of MagnetOs to form angiogenic tube networks, causing increased vascularity and ability of those vascular systems to deliver additional growth factors and cells to the site.
That's super helpful. Drew and Fahim, I'll invite you guys to come back on camera and back. Any questions for Casey before we let her go?
That was a great presentation, great summary. I can tell you, Alpesh and Casey, like I've taken patients back for adjacent segment add-ons and surgery, and where I'd laid MagnetOs previously, there's robust lamellar bone, and sometimes to gain access to the instrumentation, I would take an osteotome to it, and in doing that, I mean, it's viable bleeding bone. There is, the area does seem to kind of grow bone from the inside out. So there may be some loose granules on top, but once you scrape those away, there is a robust fusion that is live. So that was really fascinating to me, the first couple of patients that I took back for adjacent segments where you saw that.
Yeah, Casey, thanks for summarizing that very nicely. There's a lot of research, basic science behind it, years of understanding. But to me, the aha moment that kind of opened my eyes about this product and its abilities was just, recruiting these M2 macrophages and knowing that those can then differentiate into osteoblasts. I mean, it's really remarkable to understand that side of the biology and know that we're actually inducing osteoblast formation with these macrophages. So thank you for summarizing that.
Of course. Thank you all.
Great. Thanks, Casey. So we'll go on to part 4. Drew, we're going to talk us through some issues around safety, and then we'll have a really good discussion on safety. I think this is really, obviously, for all of us as surgeons, high priority.
Yes, sir. Thanks, Alpesh. So we touched a little bit on this in terms of some of the discussion we've already had, but we do worry about the safety of using some of these products because some of these products do have some collateral issues that we need to think about. In particular, what are our concerns? When we think about BMP2, this is linked to ectopic bone growth. So you can get some bone growth outside the area of where you want it to grow. There is an inflammatory cascade that comes with this. Our group has published fairly extensively on some of the radiculitis we see when we use BMP around exposed nerve roots. We also wrote a paper looking at the effects of BMP in the lateral space when doing lateral fusions and how there was a higher incidence of post-op dysesthetic symptoms and thigh pain. And then the dosing of BMP has been implicated, to cause seromas and things, especially in the cervical spine, where it was poorly understood at first, and there were some catastrophic issues that arose as a consequence. Cell-based allografts, we talked about a little bit earlier, and I said we'd come back to it. There was a breakout basically of TB and infectious disease transmission risks with some of these cell-based allografts in the not too distant past. So these are things that are very worrisome, especially when implanting it into patients that may be a bit vulnerable. DBMs and allografts, they vary in quality and processing standards. So this may be less about disease transmission and more about a poor quality of substrate that you're actually implanting in the patient, which may affect your ultimate fusion rate in spine. We look to some of our societies and organizations and congresses. There have been some guideline documents that have come out from NASS, the AAOS, and VAC committees. They urge caution in the use of biologics without robust clinical evidence, back to what we had just discussed about how much proof do you need and what type of evidence do we want. AOS talked about assessing risk and evidence across product categories, like I just demonstrated. And then there have been increased scrutiny for infectious disease and regulatory clarity, as well as cost effectiveness, which we're going to get into a little bit later. At this point, I think what we'll do is we'll talk a little bit more of Alpesh, if you want to go ahead and take this over, and then we'll get back into specifics. Thanks.
Yeah, for sure. No, great job. Great job. And again, for the audience, we're trying to be intentionally very concise on the slides. So I hope you don't feel like we're cheating you out of some slides. We all see enough slides. We want the conversation. So I'm going to ask Fahim and then Drew, when it comes to safety in the biological setting, and I want you to, if you can, if this is part of your practice, talk about the adult setting, maybe unique adult populations. And then we had a great question, it looks like, from John Seitzler about pediatric populations, right? So when you think about safety in biologics, what is it that keeps you up at night? What do you worry about the most when it comes to these biologic products, Fahim?
Well, there's several things. I mean, I think Drew summarized those nicely with with the issues around BMP and cell-based products, disease transmission. Cancer risks have been brought up with BMP. Osteolysis at certain dose, knowing the right dose for BMP. There are a lot of issues, and nowadays, I think our patients are very knowledgeable and savvy about what is being put into their bodies to help with the fusion. So I often get asked, what are you going to be using? Are you going to be using BMP? And there are patients that do not want BMP for a variety of reasons that have been in the lay news. And so I try to find the safest product that's most effective. And I think autograft, obviously mixing that with a lot of extenders such as MagnetOs has been very, very successful in my practice. I think to the peds issue, again, those safety issues are paramount. And although I think MagnetOs hasn't been studied formally in the pediatric population, it's a safe material, and I think it could probably be extrapolated, to be used safely in the pediatric population.
Drew, how about you? What when you think about biologics, what is it that makes you break out in a cold sweat or keeps you up at night when it comes
Yeah,
to.
I think one of the things that we haven't touched upon, even in my presentation a minute ago, is sort of the concept of women of childbearing age and some of the potential risks to the fetus if you use BMP. We actually have a specific consent form for BMP at our hospital, where we have patients that are going to be getting BMP sign that consent, and it talks about, some of the teratogenic effects of BMP, also some of the potential consequences if somebody has had. I kind of go the standard orthopedic, anything that metastasizes to bone, I try not to use BMP in. So, anybody who's had a history of renal cell carcinoma, lung cancer, thyroid cancer, breast cancer, prostate, and I throw melanoma in there too. I look for alternatives, and that's where I found a nice home for some of these advanced synthetics like MagnetOs.
Yeah.
And I agree with Fahim. I use it as an extender.
Yeah. I will tell you, the side effects and the side effect profile from different biologic agents are probably the thing that I worry about the most. I think you guys hit on really deep, meaningful complications, right? Things that may have to do with teratogenesis and the oncologic environment. Drew, you mentioned about, women of childbearing age who may go on to have children, and is there some effect that can come about from antibody production, right? From BMP. These are big unknowns, really big unknowns in our world. I think also about the immediacy. Like I've had enough patients with post-op, inflammatory radiculitis that I mean those patients, yeah, they may eventually do well, but it's a pretty miserable 3 to 4 to 5 to 6 months, of really bad neuropathic pain. Um, I've had patients with seromas, right?
Aroma,
Using
right?
different biologic products.
Yeah.
I haven't seen that with the MagnetOs product, but I
No.
certainly saw it when I was using a lot more BMP. So for us, in our practice at Northwestern, and my practice in particular, moving away from a product like Infuse, like BMP, has been a pretty high priority for a long time. We just haven't found anything that sticks in our practice, if you will, right? That we see people adopt and continue to use until we brought, this MagnetOs product into our practice back in 2020. And we've seen pretty consistent growth in utilization. We've seen a drop in our use of BMP. We're not seeing higher non-union rates. We're not seeing anything that suggests safety implications or somehow taking a less than outcome, if you will. So I want to
And
move on because we have about 22 minutes left if we're going to stay on time. And we're going to talk about outcomes next. Talking about outcomes, Fahim, I'm going to give you the control and have you lead us through a couple of slides on outcomes, and then we'll have a discussion there.
all right, thanks so much, Alpesh, and thanks for the invitation to be here. I think, for outcomes, obviously as surgeons, we want to get the best outcomes, and so do our patients. But we're not the only players in this, with vested interest. So, our hospitals, the insurance providers, they also want us to be successful with our patients and what we do. And, for surgeons, we all care about obviously getting the end result, the fusion, reliable every time. It's predictable, reproducible, and it's great in the routine cases. The single level fusions, the cervical fusions. We can get good fusion with most materials. But how about in those really challenging environments? The diabetics, the obese people, the smokers, multi-level. And then we want to have something that doesn't add too much time or expense to our cases. You don't want to be centrifuging a lot of things, adding new equipment, and a lot of hassle to preparing a bone graft. Getting it out of a freezer that has to be kept in a special place and is far away. I mean, all these things make a difference to us as we perform these surgeries. And obviously we've touched on this before in the safety talk, but we want something that's very safe and has the lowest risk for our patients. And I think patients want similar things. They want to get better quickly. They want obviously to fuse if that's the goal at the end. They want very few complications such as the post-op radiculitis or the back pain along the way. Obviously, if we're fusing and fusion happens faster or more reliably, they're going to get better in terms of back pain faster. And our patients are savvy. They know some of these products and what they can potentially be at risk of, and especially with any uh, allograft material, cell-based material. There's disease transmission as a potential. They'll ask that. BMP has its own set of risks, and many people are aware of that now. So we have to have those discussions if we're going to use those products, and um, and ultimately, they want a better life after we're done with the surgery and they've recovered. Hospitals obviously care because they want the same things. They want safe and reliable products. They want fewer readmissions for postoperative complications, but also for long-term non-unions. I mean, that adds to the cost for all of us. And and then they want to maintain good costs with the inventories and then using products that can actually be presented to our value analysis committees easily and have good level of data to support the products and their use. I mean, I think this makes it very easy to get things into the hospital and used quite frequently. And then, the insurance providers are looking more and more for level 1 evidence to justify the use of anything. And so, ultimately they want to look at our reoperation rates and revision rates and hope that they're lower. And they look at, our overall costs of, care for a procedure or a patient, and what that means for the system. And like everyone else that's vested in this, we want to see, reliable outcomes. So and this is a busy chart, but it signifies how us as surgeons are looking at non-unions. This was a recent publication in Journal of Neurosurgery by Steinmetz and his group. But basically, it's a busy slide, but asymptomatic patients after 12 months were considered to be successful fusions. And those patients who had symptoms like axial pain or radicular pain greater than 12 months, regardless of the radiographic analysis, were considered unsuccessful fusions. And, I think, these algorithms, they're just pointing out the need for us to, try to achieve successful fusions and better ways of assessing that clinically.
Great. Thanks, Fahim, for that quick summary there. I think that last slide is really good, and I'd encourage folks, if they're watching this video on their own, go ahead and pause on that slide and read through the algorithm. I think it's pretty impressive, and I love the fact that we are talking about the results of the surgeries we do based on how our patients are doing, right? I think, Fahim, you sort of led with that, right? That we as surgeons want a safe, successful outcome. We want patients to be doing well. And I think we're pretty well aligned with our patients in that respect. But you brought up a great point, which is that we've got other entities at play, right? We have other people involved in care delivery and in maybe payment processing. So if you think about hospitals and you think about payers, what do you think? How do we start to talk about how do we move towards a similar language? What do you think the right move is there? Because right now we all have different interests when it comes to outcomes. How do we start to talk the same talk?
Well, I think it comes back to, clinical evidence, level 1 evidence, outcome studies. I mean, these are the things that we can, really hang our hat on, present to the committees, to the payers, and say, look, this is why we can reliably use this material. This is why, we should do this type of surgery and we'll get reliable fusion. But I think it really comes down to the, quality of the studies and what we can show the hospitals and the payers.
Yeah. Drew, at our hospital, there used to be a time where I, as a surgeon, could just say I want something and it would happen. It was like magic. But I think that magic's gone. We now have a lot of different processes in place, which I think are actually probably on the whole good. But what's your experience at HSS? Do do they genuflect for you and get you all the things you need, or do you need to Fahim's point, do you need evidence?
Yeah, I think, we actually, for a long time, we've actually had a biology committee that looks at all the bone graft substitutes or bone graft extenders that we use, and it's a fairly rigorous process to get through for the surgeon that is sponsoring the product and also for the companies that produce these products. The biology, we call it the Bone Biology Committee, and they are sticklers about the quality of the data that comes through, the risk profile of the different materials that we're trying to bring in, and then obviously, especially in the recent past, we're looking very, very critically at the cost of these things. So in terms of the stakeholders, you're seeing the surgeon, i.e. representing the patient, and then you're seeing the hospital sort of protect itself vis-a-vis some of these committees that are basing the adoption of these materials on the science, but also on the cost. And then at the backbone of all of that is going to be the third party payer who is going to either help or not help with the reimbursement. So it really does come down to an interesting calculus that has to be thought about. And it's exciting because a lot of the companies now are coming to the table and saying, look, we need to figure out how to get these things in. So, more to come, but that's kind of what we've done. And it seems to have worked okay for us.
Yeah. I think the take home I have is, for everybody on the call, you're gonna have to probably think not just to yourself and to your patients, about the biologic products you want to implement, but you got other stakeholders at the table that you need to talk to as well. And having really strong data and strong evidence, obviously, I think moves you in the right direction. And not having that strong evidence and data, hopefully it helps you move away from products that that aren't really well supported. So we've got about 15-ish minutes left. Our next section is going to be on case discussions. So we've got Drew, I think you're up first with your case.
Right.
And we'll have Fahim give his case, and we'll stop in between each case and
No, Yeah, I'll go quick. That way we can have more time for discussion. But, I was going to present one of my adult deformity cases. I do a tremendous amount of adult deformity. But then I said, you know what, let me go bread and butter on this and let me kind of illustrate some points. So this was a 25-year-old patient, female, who came in and she had a pretty hot left-sided radiculopathy, and she had a weak foot, not a dense foot drop, but a weak foot, especially with extension. Her EHL was out and her tibant was weak. She had a large left-sided foraminal disc herniation. She had bilateral pars defects at L5 and a grade 1 lytic spondylolisthesis of L5 on S1. When I saw her, basically, I have done microdiscectomies on patients that have paracentral disc herniations, even if they have pars defects when they're super young, as long as they didn't demonstrate any instability. But this lady, it was basically the herniation was in the foramen, and I was worried because she also had some back pain and she had this pars defect. So I elected to do a one-level fusion with a PLIF at L5S1, and this was done back 2 years ago. So here's her pre-op films. Again, she had a little spina bifida occulta, you can see on the AP, and then on the lateral, a grade 1, maybe grade 1, almost grade 2 spondy of L5 on S1 with bilateral pars defects. Here are flexion extension films. I don't think she moved very much, but I think the fact that she was slipped with a foraminal disc herniation, I felt comfortable indicating her for a fusion. Sorry, I don't have the paracentrals here, I don't think, but you can see she has basically some degeneration of that bottom disc and her pars defects. This is her MRI, foraminal disc on the left. And again, I don't know if I have the parasagittals in this. Basically, I took her back. I did a very straightforward one level inner body. And what you can see on the AP view on the left, that's basically MagnetOs and local bone from the laminectomy that I packed into the gutters. I'm sorry, I thought I had this is my 6-month follow-up, but now obviously I have 2-year follow-ups, and I thought that was in here. I guess it didn't make the cut, but it is basically robust bone. And people ask me, how do you know when you look at it initially, if you have this granular stuff out there, how do you know that it's fused? How do you know you're not just looking at the granules and there's really a non-union there? What I could tell you over the last 5 or 6 years that I've been using MagnetOs is when you put it in, it looks like rice, basically, these fine little granules. And then at about 3 months, it starts to become like a cloud. By about 3.5 to 4 or 5 months, I usually get x-rays at 3 months and then at 6 months. By 6 months, you'll see a lamellar ring around it. And then by 1 year, it's just a sheet of bone. I don't know if Alpesh or Fahim, you've had similar experiences, and it's
Yeah.
really impressive on the deformity patients, like I said, where you'll get just an ice skating rink of bone on the back of the spine where you kind of pack it in there.
Yeah, I think I've
Yeah.
I've seen that same thing, Drew, which is that gradual progressive exchange of the product for new bone formation, and it does take time. Like it takes time to see that change occur. The other thing I like in your case, kind of I think highlights that, is that the graft tends to stay where you put it.
Yeah.
It's not a situation where the graft migrates around a bit. And it sounds like, did I hear you right? You use that in the inner body space as well as in the posterolateral space?
I do, yeah, especially depending on what type of cage I use. The cage, I don't know if I could go back or you want me to go back, but basically that's an expandable cage that expands cephalocaudal, but
Yeah.
also laterally. And the hard thing about that before I started using the Easy Pack form of MagnetOs was that I never felt confident that I was filling the cage. And now with, I just have a funnel on my back table, I could just plow some of that in there and it stays, to your point, it stays where you put it. You do have to be careful with any kind of injectable graft when you're putting it in the disc space. If the patient has an annulotomy traumatically that you're not aware of and you're really trying to overstuff it, you could squeeze some graft out. So don't do that. And remember, what we haven't talked about today, if I could take just 30 seconds, is like we haven't talked about the carpentry. It's really important to do good surgery. Like do
Yeah.
good carpentry, prepare your end plates, be mindful of these things, and then use this stuff because use these things to your advantage because they work. Fahim said something about osteolysis with BMP. I remember when we started using BMP 20 years ago, maybe 25 years ago, actually. It was horrifying when you saw your first inner body and then you just saw this giant vacuole around it. You're like, oh my God, this person's infected. They weren't infected. It was just that we didn't have the dosing down right. And all of a sudden we create this massive osteolytic event. You don't see that with these products now. You see something like MagnetOs that goes in there and like Alpesh is saying, you're replacing the product with mature bone. So pretty exciting, I think, personally.
Fahim, let's get to your case. Because I think you've got a different use case than what Drew showed. Drew, thanks
Yeah.
for that case.
Yeah.
Yeah, I wanted to show a tumor case because as Drew had mentioned earlier, I think tumor cases highlight a unique situation where you really can't use autograft bone. You don't want to use BMP. I don't personally because of, some potential risk of, increasing the inflammatory response and the tumor itself being, activated. But for that reason, I think it's a very unique environment where the synthetics can play a very, critical role. And this patient was, someone with history of prostate cancer, some hypertension, diabetes, history of TIA. He had received radiation therapy for the prostatectomy, and then he presented with 3 weeks of balance issues and difficulty with his gait. He was found to have some weakness in his, iliopsoas muscles, and gait was unstable. So, thoracic MRI scan demonstrated a dorsal tumor, epidural with some cord compression that you can see circumferentially wrapping around the spinal cord, and took him to it was somewhat osteolytic. He, brought to surgery and underwent laminectomy, removal of the tumor, and then stabilization, short segment. And this is just MagnetOs putty placed posterior laterally. And you can see this immediate post-op. And then, 4 months after surgery, this is a coronal view. He was getting surveillance PET scans by his oncologist, so we had serial CT imaging on him while he was healing, and you can see, it looks almost like mature bone at this stage, but then it still has characteristics of the granules.
But at 13 months now, this a PET scan, it's a little blurry, but you can see the maturation of the graft. There are no lucencies of the hardware, and the patient clinically was doing very well, asymptomatic from back pain. His gait was back to normal. But I think this really highlights the utility of advanced synthetics in an environment where we don't have a lot of options in terms of other biologic agents for fusion and autograft. So, I really rely heavily on synthetics to, provide the bone graft material here. And, more and more of our cancer patients are surviving longer and need to fuse, and just it's not just a stabilization procedure. For some patients it can be, depending on the tumor pathology, but I think a lot of our patients with spine metastases live longer and need to fuse in the areas where we operate.
Fahim, I think that's such an important concept, that last thing you just said. So I'm so happy you shared that case. Is that, I take care of a fair number of patients with metastatic cancer, and you're right, they are thankfully living longer across many people, like years, right? So we think about this conversion or this thought process of cancer for some people becoming a chronic disease as opposed to an acute, end of life disease. And so you bring up a great point, which is, in that setting of let's say metastatic cancer or cancer, we don't have a lot of choices, right? Are you using autograft still for that patient? Are you harvesting iliac
No,
crest autograft?
no. When they have cancer and it's spread, I really stay away from any autograft use in the fusion.
Yeah. And I think, when it comes to these kinds of CT scans post-operatively, you did a really good job describing sort of what this product looks like over time. I think we've all, those of us who have been in practice long enough, we've been through a few iterations of different biologic products that have come up over the last 20 years. And we've been burned where we see X-rays that look great. Drew, to your point, right? The films look great. CT scans look great. And then you have to take them back for a non-union, or you take somebody back for an adjacent segment, and you actually see what the fusion bed looks like, and it's just granules, right? You don't actually see de novo or new bone forming, I should say. Fahim, Drew shared an experience earlier with an ASD case. Do you have any examples like that where you've gone back and, what have you
Yes.
seen? You showed
I
it
had
in PT, but what have you seen in real life?
Yeah, I had a patient that I had to take back at about 6 weeks for persistent seroma, and no, non-infectious, but opened things up, and exactly the same phenomena. It had already formed, fairly solid bone. I mean, it was rock hard. You could chip at it, and it was resonating, bone sounds, and very impressive at that time frame. Um, and
Yeah,
I'm sure it's
I
not
haven't seen it at
solid.
6 weeks. I've had patients go back where I've had, like a post-op infection, and you have to go back to wash them out, and then, there's not a lot of bone that's formed in the first few weeks. But I've had sort of what Drew's had as well, which is, take somebody back a couple of years later for an adjacent segment, and there is pretty robust vascularized bone that's there. There are always some granules because of the way this denatures over time, but good vascularized bone. So we are actually up on the hour, but I really want to make sure we cover the last topic here, which is about costs, right? Because we've talked about some really cool things that we've got for patients. We've got safety information, we've got evidence, we've got outcomes to look at, but in the end, it's cost, right? And we really have to think about the costs that we're creating when we think about new biologic products. And I really only have one slide, to talk about, and I'll invite again both Drew and Fahim to jump back on the video. When I think about fusion success and costs, right, I think about this 2x2 grid, and we've seen a lot of where we want to be is in the top left corner, right? We want a high fusion success at a low cost. Now, what is low? What is high? There's a little bit of discussion about value, right? But we don't want to be in the bottom corner, which is a low fusion success rate and a high cost. And at least personally, I've seen a lot of products over my career that live in that category. They've gone through that very bare bones level of evidence to get to market, to get over that, FDA requirement, minimal manipulated tissue, whatever it might be, and they get to market at a high price point. Uh, Again, I'm going to call it out because I've seen this in the data. I think a lot of cellular-based allografts live in this world, right? Where they're really high cost, and we have the amount of evidence we have to suggest any true efficacy, let alone cell viability, is very low. And then I think about these other two areas where we have really cheap products that are in market, but they don't work really well. And at least at our hospital, our shelves are full of them, where we've got products that, they get through because they're really inexpensive, but we don't really know if they work, right? And again, I think of a lot of DBMs live in this category for me. So I don't really use them because even though they're cheap, if they don't work, is that really value, right? And then obviously the high cost, high fusion success rate, in my mind, a lot of that's where the BMP lives, right? It works. You get bone formation. Sometimes, if we've been in practice long enough, you've seen ectopic bone formation, and sometimes you get too much bone that forms, let alone the seromas and the radiculitis issues. So this is a way that I start to think about it, and I think in that top left corner is where value lives, where if we can identify something that's creating high fusion success rates with low complication rates, we're living in value as long as the cost is less than what we see in the extreme ends, right? That's my take on cost. This is not the product we're talking about tonight that we've talked a few times about, which is MagnetOs, is by no means a cheap product. Like, we're looking at a high value product. As we wrap up the discussion, I'd love to know, Drew and Fahim, how do you guys think about cost in this setting? And how are we going to be good stewards, moving forward as we think about all the different products that we want for our patients in the spine surgery world?
Want to go first, Fahim?
Go for
Yeah,
it.
go ahead, Drew. Oh, you want me to go? That
Either way, it doesn't matter.
No, I think you bring up great points. I mean, we all want something that works well at a reasonable cost. I think it's hard to get it for nothing. But products that have gone through rigorous studies and shown efficacy, like MagnetOs, they're not going to be on the lowest end of the spectrum. But I think, to me, it's offset by the reliability and the safety profile. And it's still at a lower price point than BMP or some of the cell-based matrices, without the potential risk and reliability issues. So to me, that the net balance comes out ahead for these advanced synthetics for most of the the use situations where I'm looking for a good fusion matrix.
Drew, if you owned your own hospital where you took home all of the profit from that hospital,
Be a good day.
would you bring a product like this would you bring a MagnetOs like product into your hospital?
I think Fahim said it best, or maybe you said it, Alpesh, before when you were looking at the chart there. I think you're not talking about an inexpensive product when you talk about MagnetOs, but you're talking about a high value product. I think when you take into consideration secondary costs in terms of complications, when you think about, some of the things with cell-based allografts where you have to store them. I remember we had a cell-based allograft that had to be scored at a very specific temperature, and the only place we had that type of freezer was like in the bone bank, and that was like in another floor. I mean, it was torture to kind of get that stuff out, and if somebody forgets to take it out and defrost it, so there's a lot of secondary cost that comes into some of these other products. This is a very durable, has good half-life. I mean, it's not cheap, but it's not BMP expensive, like Fahim said. And it works. So, I mean, like when you think about it from a value proposition, it's a good value proposition. That's kind of how I would think about it. And would I bring it in? I think I would, because it's relatively quick to prepare. It's very good to utilize. It stays where you put it, like you said. The complications seem to be low. The function and the success is high. I think that's kind of in my mind what I would be looking for.
Yeah, storage costs are low.
Yeah, yeah, storage costs are low.
Yeah,
I-
and it's shelf stable. All these things are positives. I guess I look at it, and we don't have a bone biologics committee, Drew, but we have a value analysis committee at our institution. I'm sure
Yep,
that
Yeah,
sounds
we have the
familiar to a
same.
lot of people on the call or on the webinar. That is absolutely driven by data and cost.
absolutely.
And in the absence of good data, the only measure that we end up relying upon is cost.
Yep,
So, this is a situation where we had really robust data to demonstrate to our procurement, our supply chain. And yes, it is not cheap, but wow, it's much less than our current alternatives. And oh, by the way,
Alpesh,
really
Alpesh,
robust.
one thing I'll point out, when we went through in our own value analysis and looked specifically at bone products and how we were going to, kind of consolidate and save money on bone products, the one kind of eye-opening feature was how much diversity there was amongst the surgeons in what everyone used for their fusions. Like, it was just all over the map. And, some products which I thought no one would ever use were still being used. And and that's just in spine. I mean, we're not talking, the foot and ankle guys or the trauma guys, um, and so I hope that a discussion like this that we've had will help other surgeons kind of rope in what works and what doesn't, and there's a lot of voodoo with putting together a proper fusion cocktail and then using it in your surgery. But I think if we could come up with a reliable, reproducible, substrate for fusions that everyone can use, it would be great for, each institution and just, I think for all of us going forward.
you want to hit some of these questions, Alpesh, or do you want to? I could type them in, but
Yeah, we've got
this
a
is
few. There's a number of really good questions in here. I'll be some of them are very maybe technique specific, and we'll maybe just answer those by text by typing in. I
sure.
think there's a couple of good questions here that we can wrap up with as well. One is this question. One question was early on, and I hope Graham stayed on the call long enough to get it answered, which is that steroids, right? So what are our personal preferences around steroid use perioperatively, and do you worry about the impact of that on bone healing? We're talking about immune system and immune modulation. Steroids are one thing that we sometimes use regularly, right?
Yeah, I think it's a great question, and I think myself, I try to avoid nonsteroidals and also, steroids in the immediate postoperative period for the first 6 weeks. But, that being said, there are cases where you may have to, use it for different reasons. And I try to do that on a case-to-case basis and limit it. But someone with, bad post-op radiculitis after an anterior lumbar fusion, they'll probably get a Medrol dose pack, and it's very helpful. But I haven't seen that be detrimental to their fusion long term. But
Drew, there's a question about, I think you may have typed it in, but let's talk about it real quick. There was a question from Venkat about adding local bone, right?
Yep.
What is your thoughts on local bone?
I love it. I mean, I don't love it by itself, but I think with something like the MagnetOs, I think it really does a nice job of giving you some cells, right? Even if it's not iliac crest or if it's not any type of spun down bone marrow aspiration concentration or anything like that. I think there's viable cells in the bone. And I think it does provide some scaffolding, like we said, but then having the MagnetOs in this case as a an additional bone extender has been phenomenally helpful for me. I think it makes me like, especially when you're doing deformity cases. I mean, there's only so much bone that you can take from the patient, but then you kind of supplement it with this, and you get a really nice quantity of pretty nicely What we haven't talked about is the handling
Yeah.
characteristics of some of these preparations too, which are very, very nice.
Yeah.
Whether it's in the flex type of formulation or if it's the easy pack or whatever. I mean, there's some pretty interesting ways that you can use the stuff that's very user friendly.
Yeah. One thing I'll point out, we are on time, so we're going to probably wrap up here, guys. It is just this discussion about local bone and evidence. There's a QR code here. I'd encourage everybody to just snap that real quick and get a copy of the article. Casey showed this article earlier in the talk where one side was MagnetOs, one side was local bone. And we saw that, yes, local bone can be effective, but the base rate of fusion there is not very high. And that's consistent with what's in the literature, right? The base rate of fusion for local bone by itself as a standalone is not very high. So I think I certainly also, like you, Drew, and Fahim, I'm guessing you do as well. If there's good local bone, yeah, we use it, but it needs more than that. I do think about the host quite a bit, right? Like, so if I've got a really high risk patient, so immunocompromised, smoker, osteopenic to osteoporotic, I wonder how healthy that host bone is. And so my faith in it drops, pretty substantially. And this study showed, in smokers, an even bigger, right, difference in fusion rate between local bone versus the MagnetOs product in a level 1 study. So encourage everybody to read the evidence. This one of the other participants, Jeff Kleiner, had pointed out this idea of this question of, hey, listen, when we're faced with all this evidence, and evidence is expensive, right? Evidence is expensive to create and to generate. How do you know what's real versus what's hype? How do I know if I'm not just being sold something? And I think, Drew, you answered him spot on, which is, bring your skepticism to the table, look at the data, and here's a perfect example: read the article, be skeptical, ask hard questions of the data. And I'm sure that the folks from Kuros, if anyone would like to dig in really deep, this is a company that likes to nerd out on science, and they will go deep with you and share with you a lot of the preclinical data, right? So go deep into it if you're wondering about this and you really are going to give some thought to the biologic products that you want you want your patients to see. So with that, I will thank everybody for joining us tonight. Drew, thank you. Fahim, thank you. Thanks to the people at Kuros. Thanks to everybody at Broadwater. I want to thank everybody who's still on and those who attended and those who are going to watch this later. With that, I will thank everybody. I'll thank my co-hosts again, and we can do the rollout music like the Oscars.